Thank you very much, Olga, for the very kind introduction and a very good morning from Bahrain. It is nearly 8:30 in the morning here. So let me start here. So I'll begin with a question, and the question shows on the screen. Which of the following statements is correct? Lipoprotein little a and apolipoprotein A are similar in structure and function. Or the second option is B, 1 in 5 individuals have high LP little a, lipoprotein small a. Or it is C, till date, there is no therapy for lowering LP little a. Option D, apolipoprotein B carries cholesterol from peripheral vessels to the liver. Or the option E, high ApoB, ApoA ratio is desirable. So anybody wants to shout out the correct answer? Okay. Anyway, I'll discuss this in my presentation. So in the next few minutes or so, I'm going to mainly discuss as to what is lipoprotein A. It's small a, and I'll refer to this as LP little a for the next of my talk. I'm also going to discuss as to what is the associated cardiovascular risk with raised LP little a, and if there are any therapeutic options to reduce LP little a. So first and foremost, for those who are not very familiar with this molecule, let me just go through very briefly as to what LP little a is and what the structure looks like. So LP little a has become a hot topic in the recent years in most of the conferences, and this is highly talked about. And it is very recently cardiologists and physicians, they have started to recognize as to what LP little a is, but still I find that a greater proportion of healthcare professionals, they are not very well aware of this molecule. But the fact is that this was known almost 6 decades ago. And Kerberg, a Norwegian researcher and a professor, discovered this molecule back in 1963. So this is something not very new. It was known for a very long time and over 6 decades. So essentially, lipoprotein A or LP little a is an LDL-like particle, but it has also got another molecule which is highly polygenic protein, which is apolipoprotein small a, or in small you can say ApoA, that is coiled around the LDL particle. Now just to show you this more closely, as you can see in the yellow is the LDL-like core particle, and LDL, we are all familiar what LDL cholesterol is. But you will see ApoB 100, which is in blue. And then there are some loop-like structures, which are called kringles. And they can be of variable numbers. They can be 3, they can be 4, and there can be many more. So these are called the kringles or the coils. And this is the small polysaccharide. It is highly polygenic polysaccharide, and it is called ApoA. So this is a complete molecule of lipoprotein A structure. Now this is attached to the LDL particle, and ApoB is already there. And little a, basically, it competes with plasminogen. And plasminogen, as you know, is a structure that helps to converts into plasmin, and plasmin breaks down the fibrin, and that's how it breaks the blood clot. Now, apo little a or lipoprotein little a or LP little a, it competes with plasminogen, and meaning thereby it inhibits the plasminogen to convert into plasmin, and it also inhibits the plasmin to break down the fibrin strands in the thrombus. So essentially what it does, it inhibits the breakdown of the thrombus, and it promotes thrombogenesis. So the pathophysiology is not very complex, I would say. Now we understand this molecule quite well. And as I was explaining the structure, so LDL, which you all know, the core, it increases the atherogenesis. The LP little a increases thrombogenesis because of the mechanism that I explained. It competes with the plasminogen, but it also carries, if you can see something in red there, so which is the oxidized phospholipid, and this greatly increases the vascular endothelial inflammation. So putting all three together, they do form a very lethal molecule, and this increases the risk of cardiovascular disease compared to LDL 4 times. So LDL, we all know it's bad for the heart, it's bad for cardiovascular disease, bad for future heart attacks and strokes. But certainly LP little a is more lethal, 4 times more lethal, and it increases the risk of cardiovascular disease at least 4 times higher than the risk that is there with the LDL molecule. Now it has got two isoforms. There is a large apo little a and a small apo little a. Now large apo little a, they have got a variable number of crinkles which are much higher in number compared to the smaller LP little a. And the LP little a, which is smaller and which has got small molecular weight, is much more atherogenic, means it can cause atherogenesis or thrombosis and stroke and cardiovascular disease much more than the one with higher molecule. Now we all know this is genetically determined. So people who have the elevated LP little a in their bloodstream, they had it since birth. And so it is present on the LPA gene on the reverse strand chromosomes 6q27. And it is autosomal dominant, means there's half and half chance that one can acquire it. Now in the audience, I can see there are about 40 individuals sitting. So there's a high chance that 1 or 5 of you will have LP little a. So you can say at least 5, more than 6 of you will probably, or maybe 7, will have LP little a amongst the 40 individuals. So the prevalence is 1 in 5 individuals worldwide will have elevated LP little a. So this is highly prevalent. And unfortunately, it is a bit sad that a lot of people, they do not know, even including the healthcare professionals, they're not very well aware of LP little a. And as I said, the prevalence being 1 in 5, so at least 1.5 billion people all across the globe, they do have elevated LP little a. Now, some of them, they know that the LP little a is high, but sadly enough, majority, they do not know. And the study was recently conducted in the US, and they found that only 1% of the US population actually got the LP little a tested, so which is a very low number still. And compared to familial hypercholesterolemia, which we know about, the prevalence is 1 in 300. So 1 in 300 compared to 1 in 5. So that comparison itself showed that LP little a, the prevalence is much higher. And it is very similarly distributed amongst men and women. And as you can see, there is some variation in the ethnicities, and it is the African and the South Asian population who do have a higher prevalence of LP little a compared to rest of the regions in the world. Now, as I said, that it greatly increases the risk of future cardiovascular disease. And some of the examples, as you can see here, the numbers, it increases the risk of future myocardial infarction by 3 to 4 times. It increases the risk of ischemic stroke by 1.6 times. It also increases the risk of cardiovascular mortality by 1.5 times. Increases the risk of peripheral arterial disease, all-cause mortality, both are increased. But also, this is something I would like to emphasize, that it is also a risk for calcified aortic stenosis, and the risk is not small. As you can see, it does increase the risk by 3 times for any future calcified aortic valve stenosis. Now, it really matters what the level is. Now, if you ask me, does it matter the LP little a level is 15 to 30 milligram per deciliter, or if it is more than 50 milligram per deciliter? And as you can see here on the slide, that higher the level of Lp(a) in your bloodstream, higher is the risk of future cardiovascular disease. Now, if somebody has got Lp(a) less than 15 milligram per deciliter, then the risk is obviously small or no risk, but the risk suddenly starts to increase once the level gets above 15 milligram per deciliter. And when the risk increases or it reaches between 30 to 50 milligram per deciliter, then this risk is certainly much more substantial. But when the level of the Lp(a) goes above 50 milligram per deciliter, then certainly there's exponential rise in the future risk of cardiovascular disease. And the risk increases by at least 31% for more chances of heart disease. Now, we have got different methods of identifying patients who are at risk of future cardiovascular disease. And we aim to do a primary prevention and secondary prevention. And we adopt a strategy to do this, to primary prevent and secondary prevent. And before that, we risk stratify these individuals. And we have got different scores and different means of risk stratifying them. Now, if Lp(a) was not included in the risk stratification, then certainly the risk classification will be underestimated, both for primary prevention and secondary prevention. And also the strategy to prevent the patients by means of primary prevention and also secondary prevention will be very different. So Lp(a), once we know what the Lp(a) for an individual is, then one, we have a better way of risk stratifying them for their future cardiovascular risk. And also it also guides us as to plan or management, which will be more effective in preventing, in leading to primary prevention as well as secondary prevention. So it is extremely important that Lp(a) is checked in the individuals whom we are going to risk stratify to know their future cardiovascular risk. Now, there are different international societies, and they have got all a different perspective as to who are the individuals who should actually be tested for Lp(a). Now, should it be checked in all individuals? And it is only European Atherosclerotic Society, Lipid Association of India, and Chinese Medical Society, they support that Lp(a) should be checked in everyone at least once in their lifetime. But all the societies which are mentioned on the left, AACE, NLA, AHA, American College of Cardiology, Heart UK, Canadian, they all agree that if there is a family history of premature cardiovascular disease, which means if somebody's parents or a first-degree relative had an atherosclerotic cardiovascular disease less than, say, 60 years of age, then that becomes a history of premature cardiovascular disease. Then in those individuals, the Lp(a) should be certainly checked. But some societies also agree if there is a personal history, if somebody had a premature cardiovascular disease, somebody had a heart attack or stroke less than 40, less than 50, then their Lp(a) should be also checked. And there are also a few guidelines. Some international societies put a guideline if the people are trying to reduce LDL cholesterol levels, and for some reason you have utilized all the modern therapy to reduce LDL cholesterol, and if the LDL cholesterol is not getting down, then you must suspect that this patient may have high Lp(a). So here is also an indication where you can check Lp(a) to make sure that this is not the hidden risk, and you will have a different strategy to manage the lipids in these individuals. Now, Lp(a), we must know that first what Lp(a) is and what exactly it involves as we investigate. So it is a very simple test. This does not require fasting, but if somebody or your patient is coming for a lipid profile test, then they may or may not fast, depending on if you're looking to have a triglyceride check. But it is, first of all, important to make them understand as to what Lp(a), because education is important. Patients equally need to be aware of as to what Lp(a) is, how they pose risk for their future cardiovascular disease, and certainly how it is tested and what we can do for them once we see that their levels are higher. So as I said earlier, the normal cutoff, once the Lp(a) does rise above 50 milligram per deciliter or 125 nanomole per liter, then the risk is very substantial and there's exponential rise in the future risk of cardiovascular disease. Now, the next part of my talk will be to see as to what are the therapies that can be offered to these patients. Now, the question is aspirin of any benefit in these individuals? And there have been certain studies that have shown that aspirin probably does help to reduce the future cardiovascular risk. And if the patients are on aspirin compared to those who are not on aspirin. So ASPRI trial is one of the trials that studied more than 12,000 patients, and where the patients did have elevated Lp(a) and compared to patients who did not have Lp(a), compared to people who were only carriers of Lp(a). And this did show that patients who had higher Lp(a) and if they took aspirin, then this helped to reduce the risk of future cardiovascular disease as well as cardiovascular mortality substantially compared to patients who were not on aspirin. Now, this was another article that was published only recently, January last year, that again showed the benefit of using aspirin in reducing cardiovascular risk in patients who had elevated Lp(a). And as you can see here, the patients who had higher Lp(a), and if they were put on aspirin, then there was a 46% relative risk reduction in the cardiovascular events compared to patients, in patients who took aspirin compared to those who did not take aspirin. So it concludes that aspirin certainly is a choice, important choice for preventing future cardiovascular risk and cardiovascular events in patients who have got higher levels of Lp(a). Now, is there any definitive treatment for reducing Lp(a)? If this question was asked a few months ago or 1 year ago, then the answer was, as you can see, the empty shelf, and the answer was certainly no. There was no definitive treatment that would substantially reduce the level of Lp(a) compared to all other therapies that are present at the moment for reducing the other cardiovascular risks. But now we have started to have some hope, I would say, on the horizon that yes, there are some pharmaceutical intervention that can be helpful to reduce Lp(a) and eventually reduce the future cardiovascular risk that is associated with elevated Lp(a). Now, one common question I'm asked, and most of you will be asked, that can lifestyle change, diet and exercise, can that help to reduce Lp(a)? Now, the answer to this is no. If you adopt a healthy lifestyle, yes, it will help to reduce your LDL, perhaps, maybe your triglycerides, maybe it will increase your HDL, the good cholesterol, but it makes absolutely no difference, unfortunately, to reduce your Lp(a). Now, there are some, now the second question is, does statin help? So some studies have shown that it has got very, very slight effect in reducing Lp(a), but essentially, by and large, the consensus is that statin, again, does not help to reduce your Lp(a). Yes, it does reduce your LDL cholesterol, but it does nothing to reduce your Lp(a). PCSK9 inhibitors we have been using to reduce the LDL cholesterol. It has been shown a very modest effect in reduction of Lp(a). So what are the therapies then that are available? So until recently, there was only lipoprotein apheresis that was could be done. And apheresis, we all know that it's a method just they can reduce the particle that will filter out the Lp(a) particles. And that was the only method that was being applied in those individuals who had very high cardiovascular risk and they had very high levels of Lp(a). But medical science has advanced. A lot of research has gone into as to find the definitive treatment or therapy for reducing Lp(a). And now we know that there are things like antisense oligonucleotides or short interfering RNAs. So these are RNA-based therapies, and that they work in reducing the Lp(a) and also reducing the future cardiovascular risk. Now, a lot of these are under trial, and some of the trial results also already published. And I'm also pleased to tell you that some of the medications have also been approved, but there are only few that have been approved by FDA for use in patients. But again, you have got to remember that the indications must be very strong and patient must meet all the criteria before you can use these injections, because these injections are not cheap, they're quite costly, and also they are not still widely available. We do have in Bahrain a couple of these medications that have been very recently been introduced in the market. Now, the Cyran is a long duration small interfering RNA targeting lipoprotein, and this is given in the form of injection. And it has shown that it does significantly reduce the level of Lp(a) in 2 months and 6 months. And therefore, it is beneficial not only to reduce Lp(a), but also has been found to reduce the future cardiovascular risk. And likewise, pelacarsen, it has also been shown to significantly reduce not only LDL level by 11%, as you can see here, but it also reduced the Lp(a) by at least 67%. So pelacarsen is a new drug, and it has been introduced in market in some countries, and this is available now for use in individuals who have got high Lp(a). Now again, another good news is we all look for alternative, and a lot of patients do not like injections, and now there is something called oral movalapin, which is again a wonderful molecule that has been shown to reduce Lp(a), and this is available in oral form, oral movalapin. And this was published again in November last year in JAMA. It has been shown that it will reduce Lp(a) up to 65%. And some studies are still underway as to look at what the effect is going to be on the future cardiovascular risk reduction. Now, Kraken clinical trial is a small trial that was done only in 233 individuals from different regions across the globe. And this compared the oral movalapin against placebo for over 12 weeks. And this showed that oral movalapin compared to placebo did reduce the Lp(a) by 70% by the traditional method of blood testing, and up to 85% by another method, which is called the new intact particle test. So as you can see here, this is again going to be a game changer if the future research does show that the benefit is substantial in reducing Lp(a) and substantial in reducing the future cardiovascular risk. Now, there are some consensus by ESC, and as you can see here, and all it helps us to guide as to how we formulate a plan for testing it, and if there's any treatment or management strategies that we should apply for measuring or targeting these molecules. So the consensus from the ESC does say that Lp(a) should be measured at least once in adults, and the Lp(a) should be looked into a global cardiovascular risk for that individuals. And it still advocates the intensifying of the lifestyle management, but it also does suggest some specific Lp(a) lowering therapies. The slide is a little older, so it says there are a few studies that were there in phase 2 and phase 3 trials, but certainly this is going to change now because we have got some proven therapies, and we have seen that these do decrease the levels of Lp(a) significantly, but more trials are underway, and there are more trials are planned in the future, just to see if they would have an equal and substantial benefit on reducing future cardiovascular disease as well. So we just hope there are a lot of things on the horizon out there just to see. And I believe the future looks bright in terms of finding the right therapy for these molecules so that these can be reduced and the future cardiovascular disease associated can be reduced as well. So I'll finish with some take-home messages. And Lp(a) has got a high prevalence, as I said. It exists 1 in 5 individuals, but often this is not tested, not well recognized. So it is important that we educate others, we increase the awareness that this Lp(a) is a lethal molecule, and it is actually does increase the risk of future cardiovascular disease, both heart attack, stroke, peripheral vascular disease, aortic stenosis, quite significantly. And Lp(a), I have shown that it is more important predictor of future cardiovascular risk. It is something not new. We had this for a long, long time, but we must advocate that the risk is substantial compared to LDL. Now, there are some clear indications as to who should be tested. If you ask me personally, then I would advocate that everybody should be tested at least once in a lifetime. Now, another question I get is who should be tested, at what age you can start to test. Now, there is no specific guidelines, but any individual who is above the age of 5 can have their Lp(a) tested. And treatment options I have already gone through. There are quite a few, but there are some promising treatment options that will be available soon, and a lot of trials are still underway. So with that, I thank you very much for your patient listening. And if there are any questions, I'm happy to take. Thank you so much.